Okay. Good morning, dear audience. I would like to present about the Indocyanin cholangiography for intraoperative bioduct visualization during pediatric laparoscopic hepato-biliary surgeries. I'm the pediatric surgeon from the Department of Surgery.
Comment est-ce qu'on diminue le son, tu sais, toi? Là, ben, normalement, si vous le recevez,
Sorry, please. From born.
Moi, le téléphone, c'est le minimum. Moi, l'électronique, ça n'a jamais été. Donc, je n'ai même pas pris mon téléphone.
Shall we continue?
Stephanie and Christine, your
I
audio,
think,
please.
let's wait a moment. I am host right now, right?
Yes, now you're your host, and yeah, thank you. And again, sorry, please continue.
Okay.
Thank you.
Sorry, I cannot share my okay, it's already. Okay. I would like to present the Indocyanin green cholangiography for intraoperative bioduct visualization during pediatric laparoscopic hepato-biliary surgeries. Our objective to determine the usefulness and the application of intraoperative Indocyanin green cholangiography in pediatric laparoscopic hepato-biliary surgeries. Now, the Indocyanin green or ICGs is the current usage of the new technique of intraoperative cholangiography. It has been validations of the surgical approach prevent of the intraoperative complication in adult ventilator regarding adult laparoscopic cholecystectomies. This picture shows the direct injection of ICG into the gallbladder to visualize the biliary tract during the laparoscopic cholecystectomy. So, the ICG provided greater clarity and depth image visualization and reduce surgical time. It can the advantage for the visualization of biliary tract and anatomy, vascular territory, tissue perfusion, and tumor location. This picture reveals the ICG in fluorescent excretion in the testicular vessel during the laparoscopic testicular ligation in varicocele. The Indocyanin green cholangiography in our pediatric laparoscopic hepato-biliary surgery, we can perform the basic and advanced procedures such as laparoscopic cholecystectomy, laparoscopic surgery in cholelitical cysts that includes cyst excision, hepaticoduodenostomy or root-on-wide hepaticojejunostomy, or laparoscopic hepatectomy in the liver mass. The challenging is the anatomical of extrahepatic duct and perihepatic duct vascular misinterpretation during laparoscopic surgeries. So the useful investigation for prevent these issues, we can use the intraoperative cholangiography or IOC, the magnetic resonance cholangiopancreatography or MRCP, the laparoscopic ultrasonography or LUS, and the near-infrared fluorescent NIR with ICG or called NIR-ICG. The intraoperative cholangiography or IOC have been reported to reduce bioduct injury and vascular injuries, but it has the limitation because when we use the IOC during the surgery, it can be increase the operative time, involve radiation exposure and additional resource. But the IOC is main procedure that we need to do during the laparoscopic surgery in cholelitical cysts to evaluate the biliary duct structure, common below pancreatic junction and etiology. So IOC can prevent a lateral injury of a common bile duct or common hepatic duct or vascular structure in previous inflamed cholelitical cysts. This picture shows the direct injection of the contrast to the cyst during the laparoscopic surgery. This is the contrast field under fluoroscopy, and this picture shows the cortical cyst during the laparoscopic surgery. The next modality is the magnetic resonance cholangiopancreatography, or MRCP. MRCP is the first choice technique for evaluation of pancreato-biliary anatomy. It's a high degree of accuracy in diagnosis of biliary atresia and classification of cortical cysts, but it has the limitations because it is the pre-operative investigation. So intra-operative evaluation is the limitation for this investigation of choice. And before to perform the MRCP, the patient needs time and sedation during the investigation. This picture shows the MRCP of two cases. The first case is the children with 4 years old that present with previous cholecystitis, and they have the cholecystitis. The gallstone that impact to the cystic duct like this. And this cystic duct is very close to CBD. We call the Murray syndrome. This is the difficult case for laparoscopic cholecystectomy. And the next picture is the MRCP of the cortical cyst that can demonstrate the cystic duct, common hepatic duct, and the cyst. The next modality is the laparoscopic ultrasonography, or LUS. LUS is the color Doppler application, and the transverse scanning generates the characteristics that we call Mickey Mouse appearance of the CBD, or common bile duct, portal vein, and common hepatic arteries. In a meta-analysis, there was no significant difference between IOC and LUS, but the limitation of this technique, we cannot to demonstrate the out and continuing of CBD. So we will move to the NIR or ICT. NIR ICT, ICT and near-infrared fluorescence, or NIR, is a common application of the fluorescence image guide surgeries. Use of NIR ICT require the injection of a specific dye. ICT was adopted and received FDA approved to study in hepatic and cardiac function in humans. It's an off-label specific dye for lymphatic targeting. So ICT enhanced fluorescence was improved the intraoperative anatomic view during the laparoscopic surgery or robotic surgeries, and it's increased patient safety. The ICT mechanism of actions is fluorescence produced when the water-soluble dye and excite using a light of a specific wave range in the NIR or near-infrared spectrum is about 820 nanometers, and visualization by using a specific optic and camera system. This picture shows the ICG in the water-soluble dye and fluorescent excretion in a special optic camera system. So the NIR ICT is a rapid, non-invasive, and a real-time mapping interpretation of extrahepatic biliary system without exposure to ionizing radiations. The pre-operative intravenous injection of ICG is have the half-life of time at about 2 hours and a peak wave range. The advantage of NIR ICG, we don't need to cannulate to the cystic duct or use the fluoroscopy. So it's very unattractive procedure for the intraoperative cholangiography. This picture shows the NIR ICG fluorescent contrast agent that's used via intravenous route and then use the camera system to evaluate the fluorescent excretion. Nowadays, NIR ICG device, we have the several devices. The first is the COSTARS for image one Rubina system, Striker for pinpoint system, and Olympus for visceral ELI system. The third three device is the device that can use for the laparoscopic or handheld in open technique surgeries, but it's the last one is the handheld for Hamamatsu photosonic PDE system. The NIR ICG imaging system, we use the 12 millimeters umbilical trocar with rigid endoscope for visible white light or VIS and use near-infrared illumination and imaging, a specific software that reproduces the near-infrared image in a different color through the selection of different view of mode. They have the three views. The first view is the green or blue with color and chroma mode. We can see in the blue or green, and the second one is the white mode that can see in the black and white. And the last one is the overlay density mode that in the color intense. I will show the pictures. This is the different type of mode when we use intraoperative cholangiography in the cortical cyst. The first one is the green, depending on your preference and application. You can see the hepatic arteries that fluorescence accretion in the hepatic arteries and partially in the cyst, but without the fluorescent accretion in the portal veins. The second mode is overlay density mode, that we can see the color scale on the overlay image. And the last one is the monochromatic mode, that the white and black color with the greatest differentiation. That is very greatest for clarify to identify the vessels during the perihepatic surgery. So the dosage for ICG periodic dosage about 0.2 to 0.5 milligram per dosage. We can use intravenous route, intraparenchymal route, and intraductal route. Nowadays, in pediatric usage for ICG, we can use in varicocele repair, partially nephrectomy or nephrectomy, renal cyst, Jarruphong, cholecystectomy, lymphoma or abdominal tumor removals, ovarian tumor removal, lobectomy, thoracic lymph node biopsy. Now, we will move to the NIR-ICG pediatric laparoscopic hepato-biliary surgery. Nowadays, the pediatric laparoscopic hepato-biliary surgery, we can do all basic and advanced procedures. We use the equipment with conventional laparoscopic equipment with the NIR-ICG imaging system. The ICG route, we can use via the intravenous route or direct injection to biliary tract route. The dosage is 0.2 to 0.5 milligram per kilo per dose, and the time for evaluation is depend on the operation. The mechanism of action. When we inject the ICG to the intravenous route, the ICG is entirely accretion into the bile. It can identify of anatomic structure of the color triangle during the hepato-biliary surgery, represented one of the most frequent and worldwide application of ICG guide NIR. Normally, the iatrogenic biliary and vascular damage, the key factors are inflammation and aberrant anatomy. So the ICG can clear and determine the cystic tract, the common bile duct, and especially the cystic tract. This picture shows the 2 hours after injection of the ICG in the green mode. It's the normal view that shows the liver. But in the perihepatic dissection during the laparoscopic cholecystectomy, this is a difficult case. It's very inflamed. You cannot identify the CBD hepatic artery during the surgeries, but you can see the CBD that fluorescent excretions, partially fluorescent accretion of the duodenum and liver in the 2 hours. In the 8 hours after injection of the ICG, you will see the increased fluorescent accretion in the gallbladder, but decreased fluorescent accretion in the liver, but only excretes in the common hepatic duct and common bile duct without the another part of the hepatic artery or portal vein or duodenum. So it's very clear to identify the hepatic duct injuries and prevent it. After the 16 hours after injection, you will see the fluorescent excretion only in gallbladder, cystic duct, and common bile duct, but partially in the common hepatic duct. Nowadays, the pediatric laparoscopic hepato-biliary surgery we can perform in the first one is a laparoscopic cholecystectomy, or the laparoscopic surgery for colorectal cysts that includes cyst excisions with long-wide hepaticojejunostomy, or laparoscopic cyst excision with hepaticoduodenostomy, or laparoscopic hepatectomy for tumor location. The first one is the laparoscopic cholecystectomy. We use with the normal equipment of laparoscopic equipment with the NIR ICG camera mode. The dosage is the 0.2 to 0.5 milligram per kilo per dose. And the route for ICG, we can clarify in two types. The first type is the intravenous route, and the second type is the intracholecystic injections. In the intravenous route, I think it's the two technique because it depends on the time for excretions. The first one is the 2 to 4 hours after the injections. In the 2 to 4 hours after injections, the fluorescent excretion will excrete in the common bile duct, cystic duct, and hepatic arteries, and an excretion in the gallbladder and portal vein. But if you want to use in the 16 to 18 hours after the injection, the excretion will excrete in the gallbladder, cystic duct, common bile duct, and an excretion in the hepatic artery, portal vein, and lumen parenchyma. So it depends on the surgeon preference to identify the CBD, common hepatic duct, or hepatic artery, or portal vein. It depends on the can that you want to use. And the last one is the intracholecystic injection. It's the intraoperative injection. So we will talk to the intravenous route with 16 to 18 hours after the injections. You can see this image show the advantage is can identify the critical view of safety. They have the study of Indocyanin green fluorescent cholangiography during laparoscopic cholecystectomy using Rubina technology. It's a preliminary experience into pediatric surgery center from Esposito. They use the technique because they want to identify the critical view of safety that we call color triangles. The ICG fluorescent will excrete in the cystic duct and only in the common bile duct, but without the excretion in the cystic arteries. That's the image show. They enrolled 11 patients. The mean operative time is about 96 minutes. The NIR-ICG can identify the anatomical anomalies for two cases. The first is Money-Hans-Harms of hepatic artery. That's the torsion of the hepatic artery behind the CBD. And the supravascular cystic duct. In this period of time for 16 to 18 hours after injection, it's very clear to identify the cystic duct, but in the hepatic artery, we cannot identify. So we would like to talk about in the 2 to 4 hours for ICG injections. In the 2 to 4 hours after the injection, we can identify the common bile duct, cystic duct, hepatic artery, and the portal vein. And we can use the overlay intensity mode to visualizations the position of the portal vein and hepatic artery during the resection. So this technique have the advantage for identifying of critical view of safety and vascular territories. This is the MRCP of the 2-year-old girls with the previous cholecystitis that impact cholecystitis in the cystic duct, with the cystic duct very close to CBD that we call Morrissey syndrome. So when we use the green mode, we can identify the CBDs partially in the cystic duct and liver parenchyma and partial in the hepatic artery. So this is the cystic artery. So we use the two cases for the intravenous route for 2 to 4 hours after the injections in the previous cholecystitis and cholecystitis in Morrissey syndrome. No conversion rate or the complication. Now we move to the third technique for intracholecystic route. It's the intraoperative injection for ICG, but in the literature is this technique used in adult patient only. You can visualize the gallbladder and the common bile duct and the cystic duct. This advantage, you can identify a critical view of safety, but don't determine the vasculature. They enrolled 11 patients with mean age 16 years old, no conversion or complication. This picture shows the fluorescent excretion when injected to the gallbladder and can identify the cystic duct to the common bile duct, like this. Now, we will move to the laparoscopic surgery in colorectal cysts. In colorectal cysts, it depends on the surgeon preference to perform the cyst excision with hepaticoduodenostomy or roux-en-y hepaticojejunostomy. The dosage is the 0.2 to 0.5 milligram per kilo per dose via ICG intravenous route. That I talked before, the time-dependent excretion. So after you injection the ICG for 2 or 3 hours after the injection, the excretion will excrete in the colorectal cyst, common bile duct, cystic duct, and you use overlay intensity mode to identify the hepatic artery and liver parenchyma during the resections. The unexcretion part is the gallbladder and portal vein, and partial excretion is the duodenum and pancreas. And after you finish the operation, you can detect the anastomosis leakage detection during the surgery. This picture shows 2 hours after injection of the ICG in the blue or green mode. This is a gallbladder without the excretion, but excretion in the cyst and partially excretes in the liver and duodenum. After 3 hours, it will increase in the gallbladder to identify the cystic duct during the surgeries that connect to the colorectal cyst and partially excretion in the liver parenchyma and duodenum. After that, you open the cyst to dissect in the distal parts of the cyst until to the CBD pancreato-biliary junction and excision of the cyst. This one can identify the anatomy and location that's very close to the adjacent organ of the cyst. And after you finish the operation, you can detect anastomosis leakage via blue or green mode. This case is the 7 years old with previous pancreatitis with the colorectal cyst. We use the roux-en-y hepaticojejunostomy for the anastomosis. We will move to the second case for the colorectal cyst. This case is the previous pancreatitis with pancreatic divisions. This is a normal mode. When we use the green mode, we will excretion in the gallbladder can identify the hepatic arteries, partially of the portal vein and duodenums. And when we use the overlay intensity mode, we can identify the excretion in the hepatic arteries and portal vein. When we dissect around the perihepatic area, we can use macrochromatic mode. This is the greatest visuals for identify the vessels. So it's very safe to use this technique. We enroll 2 cases of pediatric colorectal cysts. There are no anastomosis leakage or conversions. The anatomical anomalies that detect is the formicratic colorectal cyst with pancreatic divisions and anterior position of hepatic arteries. Now we move to the last one for laparoscopic hepatectomy. The laparoscopic hepatectomy, we use the ICG for tumor locations such as hepatoblastoma or hepatic metastasis. The study of fluorescent guide surgery for hepatoblastoma with Indocyanin green. In Japan, we use the dosage for 0.2 to 0.5. The time for injection is about 24 to 48 hours and wait for excretion just only in tumor location in the liver. I will show you. This picture shows the liver metastasis of the 2-year-old boy with pancreatoblastoma that have the liver metastasis. We use the ICGs in 3 mode that locate the tumor site and use for the laparoscopic hepatectomy. Conclusions. So, Indocyanin green cholangiography for intraoperative bile duct visualization during laparoscopic surgery enable a better identification of the variety and thus increase surgical safety and prevent to another bile duct or vascular injury. Thank you.
Thank you very much for your presentation.